And welcome to this fiery foot and ankle session of BOS Rising Star. Uh, to explain the concept and to welcome the judges, I'll invite President of Bombay Orthopaedic Society, Dr. Sanjay Dhar, sir. Over to you, sir.
Thank you, Ashok, once again, and welcome everyone for this one more episode of Rising Star. This time we are doing on foot and ankle, and today we have I think three contestants for this session, and we have I think two judges today. Uh, Dr. Pradeep Manot, who is a well-known foot and ankle surgeon from Mumbai, and Dr. Abhishek Kinney, again a very well-known foot and ankle surgeon from Mumbai. Besides that, we have Dr. Dhiren Ganjawala, who, as always, is with us in the session with his expert uh, knowledge of presentations and besides orthopedics. So today we'll have, I think, so far only two candidates have joined, Dr. Pulkit Bandi and Dr. Sheenam Bansal. We have one more, Dr. Chandan, who is yet to join. So for the judges and for the students, I think students already know the rules and regulations that it's going to be an 8-minute presentation followed by question answers, which your expert judges from foot and ankle and Dr. Dhiren Ganjawala will ask. For the judges, it will be an 8-minute presentation. I think Ashok has shared with you the table for their marking. It is all presentation plus the content as well as the literature review. So you are free to ask any questions to them, then you are and mark them accordingly. So that's I will take you back to Dr. Ashok, who will carry on the further.
Thank you, sir. I'll invite Dr. Neeraj Bijlani, Secretary of BOS, to invite and introduce the contestants today.
Yeah, thank you, Ashok. So today we have the Rising Star session on foot and ankle surgery. So there will be three delegates who will be talking, and we hope that one of them becomes the rising star of BOS. So the first speaker will be Dr. Sheenam Bansal. She is going to talk on surgical treatment of tarsal coalition, current techniques and outcomes. Second speaker is going to be Dr. Pulkit Bandi. He is going to talk on management of calcaneal fractures, review on surgical approaches. And the third speaker is going to be Dr. Chandan Narang, who is going to talk on Achilles Tendon Repair, a review of surgical approaches. With this, I welcome you all and hand over back to Ashok to start the sessions.
Thank you, Neeraj. And so we kickstart the session today with Dr. Sheenam Bansal. As per guidelines, you have 8 minutes to complete your presentation and followed by question and answers. So you can start sharing your screen, Dr. Sheenam.
Yes, sir. Sir, is my screen visible?
Yes.
Okay.
We can go full screen and then we can start.
Yes. Sir, is it full screen?
Yes.
Okay.
Go ahead.
Good evening, everyone. Thank you for the opportunity to present on surgical treatment of tarsal coalitions, current techniques and outcomes. Specimens coalitions can be identified from civilization samples worldwide. It is familial and it can also be associated with limb deficiencies. And it is due to the failure of mesenchymal differentiation or segmentation. Its incidence is 0.4 to 13%. Typically on plain X-ray and internal oblique X-ray, and teeter sign is can be seen in these coalitions. Variable morphology of tarsal coalition can be seen, which is osseous, fibrous. Eroded edges can be seen, which is commonly neglected. Concurrent coalitions can also be there, which can be diagnosed with the MRI. This paper showed 20% cases of concurrent coalitions. This can be seen on X-ray. We can see eroded edges, and on the MRI is showing fibrous coalition. C sign can be seen in the talocalcaneal coalition. Talar and navicular decaying can be seen due to the abnormal joint reaction forces due to coalition. These are the axial and Saltzman view, which can be seen to fully visualize the hind foot. Indication of coalition resection are pain, stiffness, or injury, which makes the 24% of the total coalitions. There is no place for casting. We resect the coalition and obtain motion. Then it can help to preserve other joints. Described techniques in the literature are arthrodesis, coalition resection, and interpositioning with fat, bone wax, split FHL tendon and extensor digitorum brevis tendon, and calcaneum lengthening osteotomy. In 1948, Harris and colleagues said about the triple arthrodesis was the most important treatment for persistently talocalcaneal coalitions, but resection for calcaneo-navicular bars. In 1987, Scranton and colleagues said that talocalcaneal coalitions could be successfully resected if they are less than half the width of subtalar joint surface. But it was data-free conclusion. Then in 1994, Wilde and colleagues put forward the same thing, but with the full evidence, with the CT scan. They put forward two things, resection and triple arthrodesis. Resection if there is less than 50, arthrodesis if more than 50% surface is involved. They said that we can resect and we can do interpositioning with fat graft if there is ratio of surface area to surface area of posterior facet is less than 50%. There is no narrowing of posterior facet. Triple arthrodesis was recommended if there was narrowing of posterior facet and there was hind foot valgus that was more than 16 degrees. Ratio of surface area of middle facet to surface area of posterior facet was more than 50%. In 1998, Comfort and colleagues showed the results of coalition resection with more than 1/3 total surface area involvement were unsatisfactory. 75% were unsatisfactory. And in 2009, Scott and colleagues from San Diego told that if defect is 25 to 30 millimeter deep, extensor digitorum brevis reaches up to 64% only, and then 10 millimeter is unfilled. So unfilled, so we can put the fat. And in 2012, Mosca and colleagues showed that for a resectable talocalcaneal coalition with normal hindfoot alignment, we can resect the coalition. For a resectable talocalcaneal coalition with hindfoot valgus, we can perform concurrent or staged calcaneum lengthening osteotomy after 6 months or so. And for an unresectable talocalcaneal coalition with excessive hindfoot valgus, we can perform calcaneal lengthening osteotomy alone. And we can do gastrocnemius recession if indicated. Then in 2015, Susan and colleagues gave the totally controversial results. They showed that half patients with talocalcaneal coalitions had a coalition with more than 50% involvement, but the results differentiation were not significant between these two cases. So this paper was totally controversial with the other papers. So then in 2015, Matthew Dobbs and colleagues showed that surgical reconstruction for talocalcaneal coalition with severe hindfoot valgus deformity have significant results and has a very good AOFAS score. They did the calcaneal sliding osteotomy and calcaneal neck lengthening and medial cuneiform osteotomy. Then in 2022, this paper was put forward. We showed that the arthroscopic resection has success rate of 86% and of open resection success rate is 80%. So they put forward the arthroscopic resection technique. So future direction is we can use live navigation with the portable CT scan, and so we can treat complex coalitions very efficiently, and their CT scan dose is also very less. Thank you so much.
Thank you, Dr. Sheenam. You finished in 6.5 minutes. So over to judges for questions. First, Dr. Pradeep, you are around?
If you can stop sharing. I think excellent presentation. A lot of data to actually go through it, and even us as foot and ankle, still you had to grasp with the slides of each. There was a lot of content on each slide, so very good. So question is, if you have a subtalar coalition, right, and a 14 or 15-year-old, oh, no, let's change that. If you have a subtalar coalition who comes at the age of 25 or 28, okay, with a hindfoot valgus, how are you going to treat it? Are you going to resect it? Are you going to fuse it? Or what are you going to do? Because you presented both sides of the story. Somebody, Mahan, I think you said, you actually did not tell me the results. You said, yes, he was controversial. But what was the outcome of that paper? You didn't mention it on the slide, at least I could not find it.
Sir, they told the results were significant with the more valgus and with the less valgus.
So, but that is anyway, Mosca and even the previous papers had already showed that, correct?
Yes, sir.
So there was nothing change in that. But
Sir,
they spoke about the less than 50%, more than 50% of the articular surface, they spoke about it.
Yes, sir. So that paper was totally controversial with all other papers.
In what way it was controversial? That's what I want to know. Did you read the paper?
Yes, sir. I read the paper.
So what was the controversy on that?
Sir, they
Was that even the less than 50% involvement of the joint surface, were they still doing well or they were not doing well?
Sir, they were taking 1/3. All rest were taking 50%.
Okay.
Yes.
And then
they showed the results were not different. They were equal. The change in result was non-significant.
so it doesn't matter if it is less than 1/3 or more than 1/3, the results are the same. Is that what you're saying?
Yes, sir. Sir, they are saying in some patients they did foot reconstruction, and in some patients they did only resection, and the results were equivalent.
Okay. Anyway, coming back to my question, 25-year-old with a subtalar coalition. What would
Sir,
you
firstly, I will give some cushion for cushion.
Yeah, conservative method is a field. Conservative method is a
Yes,
field.
sir, I will get MRI done to see stress reaction, any stress reaction or concurrent lesions.
Okay, so
Sir,
it's only a subtalar.
Sir, yes, sir. So then I will see if there is how much is the middle
Hindfoot valgus of around 14 degrees and a pes planus, which is partially correctable.
14 degrees, sir. Hindfoot pelvis.
Yes.
Sir, then I will do resection.
And that's it, only resection.
Sir, resection and interpositioning of the graft.
Okay. Okay. That's all.
Okay.
Yeah,
Thank you,
okay.
Dr. Pradeep. Abhishek, you are around?
Okay, by the time Abhishek is there, let me ask a simple question to, yeah, Abhishek, would you like to ask or shall I continue?
Please continue, sir. I'll come back. I'll come back after you.
Yeah, okay. Sheenam, you have done a wonderful research, the review of literature. Tell me, what are the gray zone where there is not clarity about the decision making or the treatment?
Sir, I think it should be symptomatic rather than a particular degrees that if it is more than 16 degree or less than 16 degree.
Okay. No, so the question is about the literature is not giving us a clarity. So what are those areas where literature is not giving us real good guidance? And if you have to carry out a research, you would carry out research in that area.
Sir, I will do this and I will see I will do gait analysis, or I will see weight abnormal joint forces if there are on any joint, and then I will do in the second stage I will do calcaneal lengthening osteotomy.
Right. Yeah. Thank you. Abhishek, please.
Firstly, I will see. Yes.
Okay.
Yeah, Abhishek, go ahead.
Hi, Dr. Bansal Abhishekini. So I have two questions for you, not questions. Okay, I can say questions. For me, BOS Rising Star is going to be a doctor who's going to be extremely good communicator with his patients. So for me, if this patient that Dr. Pradeep just mentioned, 25-year-old female who comes to you with a talocalcaneal coalition and this, how will you counsel him or how will you counsel her apprehensive parents who are looking for a potential groom for her, and what all things will be there? How will you counsel this patient about everything, right, from conservative? So what will be your steps of counseling, because that's very important mode of communication? How will you do that? Imagine that me and Pradeep are her relatives and you are going to explain things to us. Please go ahead.
Sir, I will tell them everything that if we
I'm
don't
sorry.
correct
I'm
them.
sorry to interrupt. Imagine we are relatives. We have come with our daughter with a calcaneal coalition, talocalcaneal coalition. Now talk as if you are talking to a relative. You are a consultant orthopedic surgeon, pediatric orthopedic consultant surgeon. Talk to us as we are her relatives. Show us your communication skills.
I will show what may be the consequences of getting it treated and what may be the consequences of getting it not treated, with the example of my previous patients, which then I will show them how it may get affect your all the joint forces later on.
Okay. Okay, we got your answer. We noted it. We'll keep it in mind. Second question is little technical, especially since you're a pediatric orthopedic surgeon. You described or you quoted Mosca's paper on talocalcaneal coalition.
Yes, sir.
How does Mosca's osteotomy change in a talocalcaneal coalition? You know Mosca's osteotomy, right?
Yes, sir. Yes, sir.
Tell me.
In talocalcaneal.
Will
Yes,
it work
sir,
in a talocalcaneal coalition? He has described it, but he's described it with certain principles. Can you tell me that?
Sir, it will change the column of lateral column, and it will change the joint reaction forces.
No,
That's
I
all.
understand. That is what it is for. Where will you start? Where will you end the osteotomy in a talocalcaneal coalition vis-a-vis a flexible flat foot? Or you do the
Sir,
same osteotomy?
I will do. Sir, for the osteotomy, I will give lateral column lengthening with the Olliers in season, and for calcaneum lengthening osteotomy, sir, or resection.
Where will you direct your osteotomy in a talocalcaneal coalition? Will it be the same osteotomy as a flexible osteotomy? Okay, no worries. Read about it. Thank you.
Okay, sir. Thank you, sir.
Dhar, sir, any questions from you?
No.
Okay. Okay, so thank you, Sheenam, and thank you, judges. Let's move on to the next contestant, Dr. Pulkit. Please share your presentation, Pulkit. So again, the time will be same 8-minute presentation and then followed by questions. Pulkit, we can't see your presentation shared. Also unmute yourself. Yeah, now it is sharing.
Am I audible, sir?
Yeah, you're audible now. So your presentation came online. Go full screen.
Good evening.
Wait, it's not yet full screen.
Is it full screen, sir?
No, it is not. Um, can you stop sharing and share again?
He's frozen again.
No, no, he's there.
Sir, my screen is full screen, sir. So,
No, but you have to start share screen again. Your screen share has gone down.
right, sir. I'll do it.
Oh, he's stuck again.
You saw his PowerPoint version, it was 2007. This is
Hmm.
23, the year 23.
Is it full
Okay,
screen now?
let's do one thing. Let's do, Pulkit, don't worry. You just go ahead with your thing. We will try to understand your slides without the slides. So don't waste time. Just please go ahead.
Right. Good evening. Thank you for giving me this opportunity to present on BOS Rising Star. My topic, which have been management of calcaneal fractures, a review of surgical approaches. So the calcaneum is the largest tarsal bone, and the optimal management for calcaneum fractures is highly debated till date. And it is as late as 2018 where calcaneal fractures should we or should we not operate was published in Indian Journal of Orthopaedics by Dr. Remard. And the goal of operative treatment is anatomical reduction and stable fixation, restore the subtalar joint, and maintain the normal width of the calcaneum. The methodology which I have used, the keywords calcaneum fractures, the extensor lateral approach, sinus tarsi approach, and minimal incision techniques for calcaneum fractures. The databases which I have searched for cohort studies and randomized controlled trials and meta-analysis are PubMed, Google Scholar, Cochrane Library for controlled trials, and Medline. My objective of review is to compare the function.
He's offline.
Yeah, probably we lost him. The problem is with the net connection. What shall we do? Shall we wait for that or?
We'll just wait a minute. Let him join back.
Just while we are there, when we are doing the presentations, whoever, when they do the introduction, their name, the institute, place, they don't mention that, or is that purposely not put in?
No, it's not put in, just the title and the name.
No, but
Okay.
nobody restricts them for that. Some people
So
do.
is that
So it's
Sorry?
not all the time like some people put, but some people mention that where they are. Some people may not.
Yeah.
So
So my question was, as a rising star, there's the presentation, are they told specifically not to put in, or it's just an open
there's
thing?
no guideline about it.
it's their discretion.
We have given them a lot of guidelines like what laptop to use. We have even sent them Dr. Dhiren Ganjwala's lecture of IROC Global. Still, nobody, they are doing like this. He is using 2007 PowerPoint in 23.
This is
We are live, huh,
means-
Neeraj?
Yes, I know, but I have to tell for the audience.
At least for the next presenter, if they like hear that, then at least they will be prepared.
It's like in phones, 2 generation back, nobody supports, neither Android nor Apple. That's what it should be. Anything.
Let me call him up and see what's the problem.
third one there, Dr. Chandan, or no? He's not there.
No, it's not there. So this is the last one.
Okay.
See, if we really want to give him an opportunity, what we can do is like he can record his presentation and then share with us by tomorrow morning, and then we will score. But yes, we will not be able to score how he answers the question, because that's the most important part.
Exactly.
It's also the other thing is it's always the live presentation or in the front of a crowd when you're presenting it. That's how you are, how's your body language, I think makes a big difference.
Yeah, fortunately he's here with he's here. Pulkit is here. Good.
Go ahead, Pulkit. Can you share or no,
We
we don't have your audio.
He's on the mobile.
And his audio is not connected.
Use Wi-Fi or cellular. Now it's connected.
Yeah, now it's getting connected.
Okay. Go ahead, Pulkit. Speak.
Yes, sir. Sincere apologies, sir. I changed the laptop. It had old PowerPoint and there's some net issues. Should I restart my talk,
Yeah,
sir?
please.
Good evening. My topic for today's presentation is management of calcaneal fractures, a review of surgical approaches. I would like to thank Bombay Orthopaedic Society for giving me this opportunity. The calcaneum is the largest tarsal bone. It is the commonest tarsal bone to get fractured. The optimal surgical approach and the management of calcaneal fractures is debated till date. It is as late as 2018, where in Indian Journal of Orthopaedics, a topic titled Calcaneal Fractures Should We or Should We Not Operate was published by Dr. Remelt, and the goal of operative treatment is anatomical reduction and stable fixation to restore the subtalar joint and maintain the normal width of calcaneum. The methodology is the keywords which I've used is calcaneum fractures, extensile lateral approach, sinus tarsi approach, and the databases which I've searched for the RCTs and the cohort studies are PubMed, Google Scholar, Cochrane Library, and Medline. My objective of review is to compare the functional outcome and complications using different surgical approaches to manage the calcaneum fractures, to provide valuable insights in choosing the surgical approach for improved patient outcome and patient care. The classification that has been traditionally used for calcaneum fractures are the Essex-Lopresti classification, depending on the secondary fracture line, divided into tongue type and joint depression type, and a CT-based classification, which was given by Roy Sanders, which is applicable till date. The two important angles that are considered in calcaneum fractures are the joint to tuber angle or the Bowler's angle and the crucial angle of Gisney. The timing of surgery is very relevant in calcaneum fractures because it is not just the bone that is fractured, it is the injury to the soft tissue, the condition of the soft tissues that plays an important role in timing of the surgery. The presence of wrinkle sign is an optimal indicator for the surgery. The two most important approaches that are being used are the sinus tarsi approach and the extensile lateral approach. The condition of the soft tissues favors the sinus tarsi approach, and the extensile lateral approach takes place in the watershed zone, after which the subperiosteal flap is raised, the reduction is achieved, and then plate fixation is done. The condition of the wound healing is an important complication with an extensile lateral approach, and hence the timing of surgery is very important in cases of calcaneum fractures. There were many studies that have compared these two surgical approaches, various meta-analysis studies, Chinese study done in the year 2018, published in the BMC Musculoskeletal Disorders, compared the sinus tarsi in the extensile lateral approach. They concluded that the restoration of Bowler's angle and the functional outcomes were similar with both the approaches, but the most important point that needs to be taken into consideration is the wound complications that were about 4 times more with an extensile lateral approach, and cases of sural nerve injury were reported much more with extensile lateral approach. Another British study that was done that compared both the approaches concluded the same thing, that the sinus tarsi approach reduces the problem with wound healing, but also achieves nearly the same adequate restoration of the displaced intra-articular fractures of the calcaneum as compared to the extensile lateral approach. There were other techniques that were used, for example, in managing in the stage calcaneum fractures for a medial external fixation to restore the calcaneal height, and then putting an external fixator and then managing it in a definitive way. There was another comparison done by Mehta et al., in which extensile lateral approach and sinus tarsi approach were combined with the medial distraction technique for intra-articular calcaneal fractures. They concluded that the sinus tarsi approach combined with the medial distraction technique is a reliable treatment for type 2 and type 3 Sanders, and it restores the Bowler's angle as compared to the extensile lateral approach. To conclude, the most important part for calcaneum fractures is a thorough history taking that involves the patient's immunological status, whether the patient is diabetic or non-diabetic, whether the patient is on steroids, whether the patient needs to be managed surgically, and in what intervention. The role of experienced surgeons in managing surgically with an extensile lateral approach has far lesser complications, as evident from a study by Fisher et al. Published in 2020 in JBGS. The displaced intra-articular fractures need to be treated to restore the calcaneal height, width, and maintain the congruity. The non-operative treatment of severely displaced fractures or failure to achieve the anatomical reduction results in painful malunion with rapidly evolving subtalar arthritis. Thank you.
Thank you, Dr. Pulkit, and I'll invite the judges for questions. Dr. Pradeep, you are here.
Yeah, fine. Let me start with that. By that time, Pradeep and Abhishek can join. Yeah, Pulkit, a good presentation. The question is like, you have given us a lot of information, but probably all information we are aware of. So would you like to tell us something where really the next research should proceed? Because you have read the literature. So what do you think where one should really focus or try to answer that question?
Sir, all the meta-analysis, randomized control trials, cohort studies point to the thing that sinus, if the patient is amenable for surgery and patient is fit for surgery, then sinus tarsi approach has far lesser wound complications as compared to extensile lateral approach. And all the studies, they point out to the same thing, that sinus tarsi approach, irrespective of the condition of the soft tissues, has a better least complication rate as compared to extensile lateral. And another study which was published showed extensile lateral approach in the hands of experienced surgeons has lesser complication rates. So
no, these all things are like are clear. So
yes, sir.
What are the gray zone?
The gray zone is with respect to the soft tissue, sir, and in Sanders 2, where whether to operate or not to operate. An article published by Dr. Remel in Indian Journal of Orthopaedics in 2018 highlighted the very same thing, that in cases of minimally displaced, less than 2 millimeters depth of fractures can be conservatively treated, and the functional outcomes are similar. So we need to be very careful as to what extent we need to go for surgical intervention, and we can get away with conservative management because the complications, the risk outweigh the benefits in those cases, sir.
Thank you. Thank you.
Thank you, Pulkit. Yeah, go ahead, Abhishek or Pradeep, who is online.
Okay, Pulkit, good presentation.
Abhishek, go on.
Yeah, thanks.
Thank you.
Like good control over the talk, at least, even though we didn't have the visuals, but I think we could understand what you were trying to put forward. That's very important. My question to you will be two different things. Again, one, someone who is minimally displaced, who doesn't need a surgery, like as per your criteria, doesn't need a fixation as per the books, has come to you saying that he wants a surgery. How will you counsel him the pros and cons of surgery versus conservative? And someone who's like grossly displaced, like a Sanders 4, how will you counsel him for an ORIF versus fusion versus non-operative treatment? So 2 case scenarios for you. How will you explain the patients?
So the first case scenario in which I need to explain the patient that if the patient has a minimally displaced fracture, I would explain that the patient will be having, even after a surgery, a prolonged period of immobilization. I won't allow the patient to immediately weight bear on it. So I would explain the patient that the pros for the surgery would be to delay the arthritic changes, the pain, the malunion. The cons would be, I would suggest that since the patient will have a prolonged period of immobilization in both the scenarios, I would explain the patient that the risks are much more with surgery in such type of fractures, and hence can go with conservative management. The second scenario, which is a higher grade of Sanders 4, patient might require 2 times surgery if I fix, and then patient ultimately with the advent of arthritis might require a fusion. So I would explain the patient that in such cases with a higher grade, the patient will have changes. The condition of joint is not good. The fracture is severe, extensive, and patient might require fusion at a later date. So I would avoid operating such cases couple of times with the complications that involve my wound healing problems, the other comorbidities that the patient might have a history of steroid intake that will delay the wound healing. So I would counsel the patient to go for fusion rather than fixation, and then later on converting it into fusion because the patient still has symptoms of the fracture.
Okay. Thanks, Pulkit. So for you and Sheenam both, actually, these questions which were directed were for us as judges, 2-faceted. Means one, we could judge your communication skill, how you talk to patient, because that's very important. As part of surgeons, you guys are coming into coming into proper practice very soon, or rather you guys must be in practice very well. And it also, question case scenarios would give us an idea of how you would tackle, or rather your grasp of the knowledge of what things are and how things are. Good. Both of you guys, keep it up. Keep rising, I would say. And stay interested in foot and ankle. It's very good.
Thank you, sir.
Thanks, Abhishek. Pradeep, sir, you're there?
Yeah, I'm here.
Yes, sir. Go ahead.
So I think good recovery by Pulkit, I would say. In spite of no presentation, I think the message was quite, and actually your research and the whole meta-analysis, I would say, was quite good. Okay, just quick question, Pulkit. If you had a Sanders 3, what would you do? Or what would you have it done?
Sir, I would get it operated, sir.
Okay, so what approach?
Sir, as soon as a wrinkle sign appears and I am fit for surgery the right time, I would prefer a sinus tarsi approach.
Okay.
And I would go ahead with the surgery.
Okay. What are the problems? You read the literature. Is the sinus tarsi approach good for a sinus 3? Or is there something else?
Sir, sinus tarsi approach with a combination of distraction technique or staged procedures, they have a better functional outcome in Sanders 3.
Okay.
Though the visualization is less as compared to the extensile lateral approach,
Yeah.
but the combination of a sinus tarsi approach and a medial distraction technique can help in getting the functional outcome as par with the extensile lateral approach, sir.
Okay. If you look at the literature, what is the incidence of sural nerve injuries of sinus tarsi versus extensile lateral approach? Which is more?
First article, sir, it was a Chinese article and a meta-analysis study done that included about 7 RCTs that showed that the sural nerve injury with extensile lateral approach is about 4 times more than the sinus tarsi approach.
I disagree on that because I think the sural nerve injury is more in the sinus tarsi because your branch straight away comes into the sinus tarsi approach.
Yes.
And that's why there is something called as a modified sinus tarsi approach. And then there is something called as the ESTA. Have you heard about ESTA?
No, sir.
So for Sanders 3, you have something called as an extended sinus tarsi. Okay, where your incision is slightly bigger. It goes posterior to the peroneal tendons as well. So you can have a better visualization. Okay, so if you have a good surgeon with good tissue handling, I think an extensile lateral approach works really very good because finally you want your joint elevation and joint reduction. Just because inexperience or people. So again, and also just for your knowledge, the whole discussion and the debate of conservative versus non-conservative or operative was started from BMG article. And this is, I think, 2016 or something, which needs to be quoted. Okay, you quoted an IGO article, which is a falling of the 18 part, but that's the main article which you should. And there was a 2 rebuffs on that, rebuffs, I would say, where people who experience foot and ankle surgeon, like Abhishek and us, we clearly know that operative works much better in a group of displaced intra-articular fractures.
Yes, sir.
Okay. Anyway,
Yes, sir.
that's all.
Thank you, sir.
Thank you, sir. Dhar, sir, any questions from your side?
Dr. Pulkit, good presentation, although you couldn't see your slides.
Thank you,
In
sir.
the literature, could you find anything regarding grafting in these fractures?
Sorry, sir.
From the literature, could you find any reference to grafting in these fractures?
No, sir. I didn't come across the role of grafting in calcaneal fractures.
And any algorithms where these are the reduction points or whatever on the which you should, could you get any algorithms like that these are the things which you have to for a good reduction? Or
Yes, sir. I came across an algorithm that was published. It showed that the absolute essential part is that it requires an anatomical reduction. Normally the heel hindfoot goes into varus, and hence the role of K wires and the restoration is very important. And the third thing was the width and the height of calcaneus need to be restored, and that is an important step. I came across an article in which there was an arthroscopic assisted percutaneous fixation. in which they had mentioned that these parameters need to be restored. So that is very essential. So that was the main parameters or the main points that were considered over the conservative management.
Okay. Yeah. Thank you.
Okay.
Thank you, sir.
Thank you, Pulkit, and
Thank you, sir.
thank you both contestants and both judges, Dr. Pradeep sir and Abhishek and Dr. Dhiren sir. Over to Dhar sir to close the session and also invite everybody for YROC.
Thank you, Ashok. Thank you very much. Thanks, Pradeep and Abhishek and Dr. Dhiren for being there as judges. Although we had initially three contestants, but one of them has not logged in spite of the reminder. I thank you once again for being there, and thanks the two candidates for excellent presentations. And I invite you both. I'm sure Pradeep and Abhishek will be there, and Dr. Dhiren will be there for the YROC, and I invite you both as well. I hope you are there as a contestant as well. Let's see the results later. So thank you very much, everyone, for being there.
We have a short YROC video, and I'll just play it, ending the session. Thank you again, everybody, and we end this session now. Thanks.
Thank you.
Thank you very much, Ashok. Sorry, I just keeping logging in, logging out.
Thank you very much, sir.
Okay. Thank you, sir.
Okay.
Have a good day,
Bye.
sir. Bye, sir.
Bye bye. I've sent you the